Hi guys, welcome back to Module 6. We are in Pulmonary Part 2. This is going to be a very focused PowerPoint presentation because you have multiple PowerPoint slide presentations on your module that I need you guys to really review closely. I picked certain slides from each of those PowerPoint teaching sets that I wanted you to pay particularly close attention to in terms of your learning. But each of those PowerPoints came specifically from their particular organization that I wanted to make sure you guys were exposed to and are very, very clear as to where you get this information. Because those guides, those PowerPoints are literally straight from the source of teaching you the different disease management, prognosis, diagnostics, and algorithms for how you are to treat asthma, COPD, and tuberculosis. So please make sure you review all of those PowerPoints. Again, they are straight from the source. You can go directly to copd.org or the GINA website specifically for asthma protocol and guidelines, but they are all listed in your module. So here we go, guys. So again, this week is part 2 of Pulmonary, and in particular, the ones that I want us in this PowerPoint and in all of the supplementary stuff on the module that's uploaded, it's all focused on these particular subjects in yellow. I also highlighted them within your module in green, just so you know what the focus is for part 2. So this week, we're really going to focus on COPD, asthma, bacterial versus viral pneumonia. Again, I can't stress enough smoking addiction. We're going to just keep talking about it, specifically because in these particular slide presentations from each of these organizations, they all specifically go into smoking addiction and smoking cessation, because that is one of the number one ways to prevent exacerbations of these particular illnesses. Please review the YouTube videos that I did upload. They are fantastic resources just to solidify these concepts that we're talking about, specifically the X-ray interpretation, very important. It's a very visual learning process that takes time in terms of X-ray interpretation. I do have some slides within this PowerPoint that I also want you to review. But again, the most important thing is just understanding your landmarks and knowing what normal versus abnormal looks like. Okay, so the first slide set that I wanted to just focus in on is from goldcopd.org. Keep in mind the Global Initiative for Chronic Obstructive Lung Disease, or also known as GOLD, are your standards and evidence-based practice for how you are to treat COPD. So this is literally a guide for practitioners to go through step A, B, and C. It's extremely explicit and very good way to make sure you're doing everything that you can based on evidence-based practice for your patient. So I picked specific slides that I really wanted to make sure that you guys paid attention to, in particular to COPD. So I will go through them here. The slideshows that are uploaded are quite lengthy. So, don't get too caught up in the minutia of it, but these particular slides are really important. So again, they go into evidence-based practice and where they are getting their levels of evidence in terms of the research that's been done to justify these protocols that they're putting into place. So they go into the basic hierarchy of evidence. This is just like the hierarchy we reviewed in module 1 and 2. It's just listed in a chart table as opposed to a like a triangle type pyramid. So again, remember your randomized controlled trials are your highest sources of evidence versus your panel consensus and judgment are your lowest evidence. So things that you want to make sure you are very well aware of in terms of considering your diagnosis for COPD for your particular patient. The first thing you're going to do is perform spirometry. We do have a slideshow on that. I will focus in on those particular slides as well going forward. But in particular to the symptoms of COPD, these are the particular things that you need to make sure you are pinpointing in your documentation. For instance, dyspnea that is progressive over time and is characteristically worse with exercise as well as persistent. Chronic cough that may or may not be productive, or also with a recurrent wheeze. And then you have chronic sputum production, also can indicate COPD. We have recurrent lower respiratory tract infections, a history of risk factors. That's a big thing, including tobacco smoke and smoke from home, including cooking and heating fuels. And of course, if they had any occupational hazards where they were exposed to any dust, vapors, fumes, gases, these are patients that we definitely want to consider for diagnosis of COPD, as well as making sure we're documenting these particular risk factors. Of course, a family history of COPD, as well as parents who smoke, those are all definite key indicators for a diagnosis of COPD. So in terms of your classification of airflow limitation severity in COPD, based on your post-bronchodilator FEV1, these are how they classify your COPD patients. So in terms of mild, moderate, severe, very severe, your gold 1 is your moderate, mild, and your gold 4 is very severe. So keep that in mind. It goes right up the ladder in terms of numerical value and versus severity. But on the other hand, your FEV1 starts higher and then drops lower as your COPD becomes more severe. Okay, keep in mind, COPD is a permanent loss of elastic recoil of the lungs, causing alveolar damage, airflow limitation, chronic inflammation, and changes in the pulmonary vasculature. Chronic and progressive dyspnea is the most characteristic symptom of COPD. And a post-bronchodilator FEV1 FVC of less than 0.7 or a lung function of less than 70% is the cutoff score for diagnosing COPD. The most common cause of COPD is chronic cigarette smoking, with the highest incidence among men older than 40 years old. Most patients have a mix of chronic emphysema and chronic bronchitis, and one or the other may predominate. Many have an asthmatic component that overlaps their COPD, and this is known as asthma COPD overlap syndrome, ACOS. There is also a PowerPoint, actually there is an article that I uploaded into your module that I do ask you read. It is all about ACOS and how that is to be managed. At this point in time, the likelihood is you're going to see more of that than you did before, specifically because a lot of these patients who are high risk for COVID are now having more exacerbations than prior. So you may end up seeing a lot more ACOS than prior. So you do need to know how to treat that and manage that in accompanying with their COPD. Keep in mind, COPD is now the 4th leading cause of death in the United States. So this is something that you really need to keep in mind in terms of always at every single visit, really reinforcing smoking cessation if possible. So in terms of your GOLD guidelines, you just really want to make sure you know how to classify group GOLD 1 to GOLD 4 in terms of their FEV and their predicted FEV values. Okay, so brief strategies to help patient willing to quit. We went through this. Hopefully you guys all read that article. This was a question on your quiz, and this will come up again and again, both on your exams for me, as well as for your boards. You need to make sure you know, ask, advise, assess, assist, arrange. These are the strategies that the CDC and the Chronic Obstructive Lung Disease Association all reinforce in terms of helping patients quit smoking. And when it comes to doing this, you also need to make sure you're documenting which strategy you used in that particular visit and what the outcome was. Very, very important. In terms of management of COPD, make sure you are aware of the symptoms, the risk factors, and the spirometry values that would indicate COPD, just like here in this chart, your spirometry values. Make sure you are aware of how to do your initial assessments and know your GOLD levels, because this will guide you in terms of how you manage it. Of course, initial management would include smoking cessation. You want to make sure these patients are up to date with their vaccinations. You want to talk about lifestyle and exercise, as well as pharmacotherapy. Definitely you want to talk about self-management, including reducing risk factors, less exposure to smoke, of course. Managing comorbidities is also key to all of this. And then, of course, you want to review and then adjust your pharmacotherapy as needed. And we'll get into that. So the other things you need to consider before you make your diagnosis of COPD, you need to consider the other following acute conditions in terms of your differential diagnoses. You want to consider pneumonia, pneumothorax, a pleural effusion, pulmonary emboli, pulmonary edema due to cardiac related conditions, or cardiac arrhythmias. Again, this slide is directly from the COPD GOLD guidelines. And it's a beautiful thing because look, even to help you differentiate your diagnoses, they give you the next diagnostic tool that you would need in order to rule these out. So these are great tools for you as a clinician, especially as a new NP when you're just not really sure what to do next. These tools have all the information for you laid out, A, B, C, D. It's really great. So please make sure you read them and keep them very close to you in terms of reference for when you do start practicing. The slides go into the appropriate vaccinations for patients who are with stable COPD. You obviously want to make sure they're up to date with their influenza vaccine because it reduces the severity of any illness and death in COPD patients, specifically with the flu. The WHO and CDC recommend COVID-19 vaccination for patients with COPD. They do talk about pneumococcal vaccine and DTaP as well, just to make sure they're on top of that. Okay, so now in terms of pharmacotherapy for COPD, your bronchodilators, in terms of pharmacological treatment, you want to just keep in mind that your short-acting beta-2 agonists, or your SABAs, which are bronchodilators, are now recommended for all patients with COPD to be used for intermittent increases in dyspnea as needed. And another thing I want you to keep in mind is if a patient has poor symptom relief with a short-acting anticholinergic or a short-acting muscarinic antagonist, a SAMA, then you're going to want to add a SABA, group A, okay? So you just want to keep in mind your different particular treatments because when you look at your patient groups or your GOLD guidelines, you're looking at bronchodilators, corticosteroids, oxygen therapy. These are the main things that we use to treat our patients with COPD. So your bronchodilators include your SABAs, your LABAs, or your long-acting beta agonists, your SAMAs, or your short-acting anticholinergics, and your LAMAs, or your long-acting muscarinic antagonists. So SABAs would include your albuterol inhaler, or Xopenex. Your long-acting beta agonist, or your LABAs, would be your salmeterol or formoterol. Your SAMAs, or your short-acting, would be your ipratropium or your Atrovent. Okay, your long-acting or your LAMAs would be your Spiriva or your Ellipta. You know, when you're studying, try to keep those straight in your head, like list them out together. For instance, when you write down SABA, make sure you put next to it albuterol. You know, I think at this point in your career, the likelihood is you guys have been exposed to these types of inhalers quite often. You just may not be aware that one is short-acting versus one is long-acting. So if you can picture the albuterol in your head, the likelihood is you're used to seeing patients go to that all the time. Like that's their go-to, right? Because it's short-acting. So again, just try to differentiate your SABAs from your LABAs and your LAMAs, okay? Because remember, those are the standard treatments in COPD, and you add one as one either doesn't work or you need something stronger in addition to help with your patient. So your group A's of your GOLD guidelines for your treatment in COPD, your group A's are your mildly symptomatic COPD patients with low risk of exacerbations. And those patients, you're going to use a SABA, usually a SABA alone or a short-acting, like an albuterol inhaler, or in combination with a SAMA, if needed, okay? Group B, now we're going up with symptoms. They're still low risk for exacerbations, but they're more symptomatic. Now you're going to use a LAMA or a LABA or a SABA for symptom relief as needed, okay? Then group C, which is minimally symptomatic, but high risk for future exacerbations. Your LAMA is your first line, and then you add a SABA for symptom relief as needed. So you need more of a long-acting when you have more symptoms, and then a short-acting for your intermittent symptoms or acute symptoms. And then group D, which are the most symptomatic, they are high risk, and we're referring them to pulmonologist. Now, to be quite honest with you, if I'm having a patient who's in group A and I don't see them really making any lifestyle changes in the near future, and the likelihood is they're going to be a group B at some point in the near future, I'm already making my referral to a pulmonologist. This patient, because COPD has such a high mortality rate, especially if it's not managed effectively, you want to get these patients in to the specialist as soon as you can to make sure they're getting all the help and best treatment available to them. So really make sure you're looking at your treatment of COPD based on GOLD guidelines and when you would be using a SABA versus a SAMA versus a LAMA, okay? These slides also get into, this particular slide is differentiating how COPD and COVID manifest when they are in conjunction and what your therapy and possible interventions would look like. So obviously these patients, if they do get a high infection rate with this COVID-19, the risk for developing ARDS and cardiac failure is very high. So these are the patients we need to hospitalize immediately and get them interventions to prevent any kind of respiratory failure as soon as we can. These patients, again, I can't stress enough, you want to make sure their vaccinations are up to date and they're really educated on what symptoms they need to be reporting to their practitioners. Okay, next we're going to just get into spirometry. Again, this is straight from the goldcopd.org PowerPoints that they provide for healthcare practitioners, and you can use this in your own practice to teach and review with your practice if that's something that comes up. You can use these slides for yourself and adjust them to whatever needs your practice needs in terms of reviewing the most up-to-date standards for COPD and spirometry guidelines. So here we're just getting into the gold standard test for asthma and COPD, which is pulmonary function testing. And it's done by pre and post bronchodilators, where they measure the obstructive versus the restrictive dysfunction. Okay, so remember your forced expiratory volume in 1 second is your FEV1, and that's the amount of air that a person can forcefully exhale in 1 second, versus your forced vital capacity, which is the total amount of air that can be exhaled during the FEV1 test. When you look at the FEV1 and the FVC ratio, it's a proportion of a person's vital capacity that the person is able to expire in 1 second. So just keep in mind that your normal values are greater than 75%. Post-bronchodilator FEV1, FVC ratio, a lung function less than 70% is the cutoff score for COPD. So keep in mind, remember, we talked about this last week in differentiating obstructive versus restrictive dysfunction. Remember, obstructive dysfunction is a reduction in airflow rates. For example, your asthma, your COPD, which includes your chronic bronchitis and emphysema, and your bronchiectasis. Versus restrictive dysfunction is the reduction of lung volume due to decreased lung compliance. And examples of restrictive dysfunction would be pulmonary fibrosis, pleural disease, or diaphragm obstruction. So spirometry is something you're going to be doing continually when you're monitoring disease progression in COPD in these particular patients. And again, at this point, unless you're working in a pulmonologist's office, the likelihood is you've already made that referral to the pulmonologist. Again, here's your review of your standard spirometry indices and what each particular acronym means and what your ratio entails. We've got vital capacity, FEV6. So they do also a forced expired volume in 6 seconds. It often approximates the FVC. It's easier to perform in older and COPD patients, but the role in COPD diagnosis remains under investigation. So they probably extended this time just because it's so hard for these patients to actually even take the breath. So it gives them a little more time to show what the results would be, but I'm sure that skews the results. That's why it's still under investigation. Okay, so now we're going to get into asthma. So this is your global initiative for asthma. And this is called, also known as GINA. And again, this is the particular guidelines that the CDC and practitioners follow in terms of asthma management. So really important you review the GINA global guidelines, and they are always, they keep them up to date. So you always want to check back to see if there's been any new information that's been added. So here they give you a beautiful diagram on how to go ahead and start your diagnosis of asthma. So you want to keep in mind that asthma is common and potentially serious chronic disease that imposes a substantial burden on patients, the family, and the community. But it fortunately can be effectively treated, and most patients can achieve good control of their asthma, when they get good control. So how do they get good control? They avoid troublesome symptoms during the day and night. They won't need their reliever medication. They have productive, physically active lives. They have normal or near normal lung function. And they avoid serious asthma flare-ups like exacerbations or attacks. This is how we keep it under control. This is a nice life for a patient with asthma. If you can keep it under control, these are the good things that can happen for these patients. They won't really need to use their inhaler. But factors that may trigger or worsen asthma symptoms include viral infections, domestic or occupational allergens, especially like dust mites, pollens, cockroaches, bird dander, tobacco smoke, exercise, and stress can also exacerbate asthma attacks. And some drugs that can induce or trigger asthma also include beta blockers, aspirin, and other NSAIDs. Keep in mind, asthma flare-ups, also known as exacerbations or attacks, can also occur even in people who are taking their asthma treatment. These are the patients that we really watch carefully because we want to get their medications adjusted so that they don't have these exacerbations. Asthma is treated in a stepwise approach, just as COPD is. So that's why these beautiful slides are so helpful in guiding us in terms of managing our asthma, because it literally gives you step-by-step, how you treat asthma depending on the patient's symptoms. So here we have a beautiful personalized asthma management step 1, step 2 medication guideline here. And basically, the first thing you need to go through is assess your patient. You want to know symptoms, exacerbations, lung function, and how the patient is feeling. We need to confirm our diagnoses. We need to look at symptom control and modifiable risk factors, comorbidities, patient preferences and goals. Very important, because you want to make sure your patient is compliant. So you need to see where they're at with their compliance and what is preventing them from possibly being compliant. We want to look at treatment of modifiable risk factors, of course, talk about smoking cessation, and then we're going to adjust our asthma medications accordingly. So remember, we talked about SABAs versus LAMAs versus LABAs. Those we have to make sure we're appropriately doing depending on what step they're in. Okay. So remember, on your initial visit, you're going to assess the asthma control to determine if the therapy should be adjusted. And then at each visit, you're going to assess their asthma control, proper medication technique, patient adherence, and patient concerns. So GINA classification and stepwise approach and treatment guidelines has been updated, and they have put their prevention guideline in 2020. This is the first major update in about 30 years. The National Asthma Education and Preventions Program had developed the guidelines originally. That was released in 2007, but the GINA is now the most up-to-date one. You're going to want to look at your asthma classifications from 12 years and up, and you want to keep in mind the components. Are they intermittent? Are they mild persistent, moderate persistent, or moderate to severe? And based on this, we're going to do a stepwise approach. And we're going to consider if they've had in step 1 symptoms less than 2 times a month, that's when we're going to consider a low dose ICS with a formoterol PRN. Or you could do a SABA with a low dose ICS. In step 2, symptoms are 2 times a month or more, but less than daily. And again, you're going to do a low dose ICS or a low dose ICS with formoterol PRN. Same thing, step three, well, not the same thing, I'm sorry. Step three, symptoms are most days or waking with asthma once a week or more. That's when we're gonna bring in a low dose ICS, a LABA daily, or a medium dose ICS with a low dose leukotriene receptor antagonist, or an LTRA. So if you look at these tables in your global initiative, you're gonna see based on the symptoms, they will make their recommendations of a low dose ICS versus a low dose ICS with a SABA. So make sure you review the global initiative for asthma, GINA, asthma management and strategies in terms of the stepwise approach and the asthma treatment recommendations. In 2007, I told you the National Asthma Prevention Program came up with their treatment recommendations, but the GINA one definitely has more to it. Big things you also want to make sure in terms of asthma is going over patient education, making sure you're reviewing how to use the inhaler appropriately, teaching them about rescue medications and long-term controller medications, the difference between the two and when they should use each. In terms of mouth care, you want to make sure they're rinsing their mouths just to make sure they're not getting any kind of thrush from these inhalers. If a patient does have an asthma exacerbation, you want to give them a nebulizer treatment. And after the nebulizer treatment, we're listening for breath sounds. If they still have wheezing that is present, it's a good sign as long as their breathing is improved. But if there's a lack of breath sounds or wheezing after a nebulizer treatment, this is a very bad sign and you want to call 911. Remember also in asthma, same thing like COPD, we're looking at our peak expiratory flow rate because it measures the effectiveness of treatment, worsening symptoms, and exacerbations. Okay. The GINA guidelines, also the slides get in, there's a whole slideshow specifically for difficult to treat patients with severe asthma in adults and adolescents. Again, this is there for your knowledge to be well aware of the fact that all of these protocols are right online, very easy for you to access, and they are the standard of practice. So you need to make sure you look at them and are aware of where you can find them if you do have these types of patients coming into your practice. So this just goes into a decision tree in terms of how you would diagnose and manage these patients. Again, these are things that you would have already referred. These are patients you would have already referred to a pulmonologist, but it's still important that you're very well aware of what the diagnosis and management would look like for your particular patient to ensure that when you're consulting with the pulmonologist, you and him are on the same page in terms of the standards of care. This is available on this website for free upload if you wanted to download it, I'm sorry. I also posted it in your module, guys. This is just more information from they're just talking about key changes to the guides that was just recently done in the GINA guide. Okay. So these are biologic markers. You don't need to really know this. This is a little excessive. Sorry, I shouldn't even have added this. Okay, next, most importantly, is tuberculosis. This is also from the CDC. CDC has a ton of great resources. This is a teaching slide set also from the CDC that I uploaded into your module. Again, I just wanted to point out some particular slides because the slides, the PowerPoint is quite long. But it's pretty basic, except for certain ones that are particularly helpful in terms of learning how to manage TB in terms of latent versus active. So these are slides directly from the CDC website. And again, I uploaded this right into your module so you have access to it, and please review them because we do want to make sure you can differentiate that the latent TB infection versus the patient with TB, active TB. Keep in mind, not everyone who is infected with TB becomes sick. So these are things you need to keep in mind. Okay, definitely you want to be aware of the symptoms of TB: night sweats, weakness or fatigue, cough lasting longer than 3 weeks, pain in the chest, weight loss, fever, chills, no appetite, and most importantly, coughing up blood or sputum. So this is number one thing. If you hear this, you're always going to want to rule out TB. I had a student come in once when I was a school nurse, and he was an immigrant, and his vaccination status was not where it should have been. And all of a sudden, he comes in one day coughing up blood, and I immediately was concerned, and I had to send him right out because we had to make sure that the student didn't have TB. Very serious, very, very serious. So just make sure you're paying attention to those symptoms. And the other thing you want to keep in mind too is that symptoms can vary in TB patients depending on the type of TB disease, all right? People with TB disease are sick. They feel sick, and they can spread TB germs, especially to people they spend time with every day. So keep in mind, your patients with TB typically require 180 days of medication, plus follow-up x-rays, lab work, and follow-up and testing of their contacts that they've been in close contact with, family members, work people, anybody they've been in close contact with. Remember, it's spread via respiratory droplets, very easy to spread. So these patients, the minute they're diagnosed or the minute there's even a question, you as a practitioner are mandated to notify the health department. The health department will follow these patients just like they followed COVID patients, where they will call them every day or check in with them every day to make sure they are taking their medicine and are getting follow-up. The TB disease is a serious condition, and of course it can lead to death if it's not treated. TB disease can almost always be treated and cured with medicine. So, but the thing is, they have to take the medicine and they have to take it correctly. Otherwise, it doesn't work. TB germs become active if the immune system can't stop them from growing. When TB germs are active or multiplying in your body, then that's when this becomes an active TB disease. Again, you can find all of this information on cdc.gov under tuberculosis. I did download this PowerPoint into your module, so please make sure you look at it. Okay, so again, just like I said before, public health workers are responsible for finding TB contacts. So like I said, the local health department does conduct a contact investigation by following up and testing those who have been close to someone with TB. Conducting contact investigations is a priority for TB programs in the United States. The goal of contact investigation is to specifically stop the spread of TB and prevent future cases and outbreaks of TB disease. So these patients, and keep in mind, you want to look at these diagnoses because how many of your patients have severe kidney disease, HIV infection, diabetes? Like these are pretty consistent diseases that we see more often than not. So if these are the types of comorbidities your patients have, then these are the patients that you want to really look at to make sure that they're not being exposed to this somehow, or you know, these are the patients that are the most high risk for developing TB disease. So you want to keep a very close eye on them in terms of screening them if you hear of any sort of cough or malaise or weight loss, because they're the most immunocompromised, especially your substance abuse users. Keep in mind, while not everyone with latent TB infection will develop active TB, about 5 to 10% will develop TB disease over their lifetimes if not treated. So progression from untreated latent TB infection to TB disease is estimated to account for approximately 80% of the US tuberculosis cases. Babies and young children are, of course, also at high risk because they often have weak immune systems. Okay, so the other big thing we need to make sure that you review for sure is your tuberculosis skin test. Also known as the Mantoux tuberculosis skin test. It requires 2 visits with a healthcare provider. One, on the first visit, the test is placed, and then on the second, it's read. And here you can see that they're reading the test. So positive skin test. So the result depends on the size of the raised hard area or swelling, as well as what comorbidities your patient has, because depending on what comorbidities they have will also indicate whether the test is positive or negative. So it's positive. If it's positive, this means that the person's body is infected with the TB germ, and additional tests are needed to determine if the patient has latent TB or TB disease. A negative skin test simply means that the patient's body did not react to the test, and that the latent TB infection or TB disease is not likely. So you need to make sure you're reviewing your indurations of 5, 10, and 15, and those test results, whether they're positive, and what their risk factors are for TB. Other labs you need to keep in mind besides this tuberculosis skin test for diagnostics of TB is your blood test for tuberculosis, which would be your quantiferin TB gold and tube test, or the T-spot TB test, also known as the IGRAs. Blood tests that measure, IGRAs are blood tests that measure gamma interferon from your lymphocytes. They're usually available within 24 hours. It's only one visit required. And if they have a history of a previous BCG vaccination, then you do want to go ahead and do the IGRA blood test. You also could do a sputum test for TB, which it would be an early morning deep cough sputum specimen, and you want to collect that for 3 consecutive days. And you can also do a sputum for CNS, which is a gold standard for diagnosing pulmonary TB, but that can take up to 8 weeks to grow for results. And if we have an active TB infection, then if you suspect an active TB infection, you're going to want to order sputum for NAAT, a culture and sensitivity, and AFP smear, just to rule it out. Okay, so of course, people with latent TB infection do not have symptoms, and they cannot spread TB germs to others. However, if latent TB germs become active in the body and multiply, the patient will go from having latent TB to becoming sick with TB disease. For this reason, people with latent TB infection should be treated to prevent them from developing TB disease. Treatment of latent TB infection is essential to controlling TB in the US because it substantially reduces the risk that latent TB infection will progress to TB disease. All right, so keep that in mind. We need to treat this no matter if it's latent or active. Again, here's your resources from the CDC. I can't stress enough how great that website is in terms of just giving you resources, not only for yourself, but for your patients as well. Here we have a TB teaching tool that I downloaded right off the internet, right from the CDC. There's tons of them. This is just one very basic one that gives the patients general information, and everything is in various languages, English and Spanish, as you can see here. So you really have a great place to go for these particular patients. If you work in any sort of clinic, these are going to be great tools for you to have, because a lot of the times you're dealing with immigrants, and these are the patients that are at very high risk, so you want to make sure they're protected and educated. Okay, next is chest x-rays. Please, please, please review the supplementary videos on interpreting chest x-rays on YouTube. The most important thing I wanted to make sure that you are understanding is the concept of consolidation. They do give chest x-rays on the boards, and they do ask you to answer multiple choice or point to the area of consolidation. So you need to understand the concept of consolidation as well as your basic landmarks. So again, I've posted a few different pictures I found online showing you different avenues of how to locate the different landmarks, which will help guide you when you're looking at an x-ray. Because again, if you know where your normal landmarks should be, then you know what abnormal will look like. Okay, so here's just a few more pictures and slides of what your landmarks look like. I like this one the best just because it's in color, it kind of differentiates it. But this is how you're looking at your x-rays, and you're looking also for air. And in air, you're looking, the air would appear as a black color or low density over a lung field. You're going to see bones, which appear as white and gray. So you can see your ribs here. You're going to look at metals, which would be bright white or high absorption. You're going to look at the tissue, which has different grayish shades. You're going to look at fluid, if you see fluid, and if you see fluid, it's usually grayish to whitish. And then you're going to definitely see tissues that are visible, which are your trachea, your bronchus, your aorta, your heart, lungs, pulmonary arteries, diaphragm, gastric, bubble, and ribs. So that's how you can start to differentiate, looking at x-rays and not, being able to figure out what's normal versus abnormal. Here's a quick YouTube video that I just wanted everybody to see. And I wanted to make sure you actually watched it because this gives you great, I don't know if it's gonna let me play it. Hold on, sorry guys. It gives you great information on consolidation. Actually, let's see if it'll let me play. It's not. Okay, so what I'll do is I'll upload that into your module so you can watch it. I'm sorry, it won't play during this PowerPoint. But yeah, consolidation is the key thing you need to make sure you're aware of, because that's most of the time what you're going to see specifically in your pneumonia. Abnormal conditions that you also want to consider reviewing are emphysema, what you would see with emphysema. Here's your pneumonia in terms of consolidation. You see all that white. That's how we know, basically you're looking at density in your left lower lung field. The left heart silhouette is intact, but you have the loss of the diaphragmatic silhouette and no shift of the mediastinum or air bronchogram. So that's where you're looking at pneumonia. You see all that consolidation, that's congestion. That's why this patient is filled, he just can't breathe. Again, here's more consolidation. So in, oh, here, I want to show you this one. So this is a good one. So we have normal versus bacterial pneumonia. You see where they're showing you the grayed area, and then we have viral pneumonia. So again, more, see this cloudiness, this consolidation. You need to be able to just make sure you know your landmarks and know when you see consolidation that it's abnormal for sure. Another thing that I would like for you to definitely keep in mind too, in terms of chest x-rays, is being able to look at a chest x-ray and differentiate pneumonia as well as tuberculosis. Keep in mind tuberculosis. Let me see if I put one in here. Oh no, I didn't, sorry. But definitely look at your x-ray on those videos. They definitely show you a tuberculosis x-ray. But consolidation is your big thing that you want to make sure you're aware of and what you're looking at in terms of landmarks. Oh, the other thing I wanted to point out to you guys too, keep in mind, is that x-rays can be in the PA view, which is the x-ray goes through the back to the front, and versus the anterior posterior view, where the x-ray goes through the front of the chest towards the back. The lateral view is the view from the side of the chest. And it's important you know which view you're looking at, because that's going to guide your systematic approach of reading the chest film. You also want to consider if you have old chest films versus new ones, you want to have them next side by side so that you can be comparing the two. Okay. All right, guys, I think that's it. So, and then I included a slide in here with your interstitial lung disease in terms of what your x-rays will look there based on the stage of their sarcoidosis. Remember, there's 5 stages. We only show 4 here, but in terms of stage 1, stage 2, well, your stage 0 would be your normal, but the 4 stages of the development of it are here, stage 4 being your worst. And there you're seeing all of that shadowy consolidation in there, the density, because that's where we're end lung stage with our pulmonary fibrosis. All right, guys, that's it for today. I just really wanted to do a focused PowerPoint because there is a lot for you to read and get through. And everything in terms of your quiz will be based around those PowerPoint slides, as well as your readings and also the articles that are posted. So please make sure you read them. Have a great week. If any of you need to meet with me, any questions, please feel free to reach out to me via email, and I will see you next week. Keep in mind, next week is a review week where we will be doing review for your midterm exam. All right, have a great week, guys. Thank you.